Okay, so now we're going to start the second part of the immune module, Module D, which is HIV. Basically, it's in your Iggy book, chapter 21. And you'll see the other, if you want to look at the other slides on 30, the other books on 35, it's also in your maternity and peds books. I'm not going to go over those. There's also CDC guidelines on caring with patients with AIDS, HIV/AIDS, and there's a website here on slide 36. Let's talk about AIDS. Basically, there was a 60% mortality rate. There is no cure for the disease. Your main focus is going to be on prevention, so education to everyone, regardless of age, gender, culture, sexual preferences. Everybody is susceptible. HIV is an infection that can progress to the acquired immune deficiency syndrome, or AIDS, which is the most common secondary immune deficiency disease in the world. When we're educating people, we not only have to educate them on the disease, but the transmission routes and the ways to reduce exposure to that. So the origin of AIDS, it was first identified in 1981. Basically, it was first seen in homosexual men and IV drug users. And then it was spread. Basically, the infection was seen in other populations. So your hemophiliacs, patients who had received a transfusion with HIV-infected blood or blood products. You saw it in newborns and breastfed infants of HIV-infected mothers. And then, of course, partners having unprotected sex with those who were infected. 2007, these slides show you basically a breakdown of how the data for HIV and AIDS in the United States. There's basically about 550,000 deaths from AIDS, 1.2 million cases being diagnosed. The mortality rate among adults is about 60%. Drug therapy does slow the disease progression, but it must be taken for the rest of the person's life. So worldwide, there's about 40 to 60 million cases of AIDS, 30 million deaths a year. If you want to break it down by demographics, 72% are non-white populations. 74% are men. Age, mostly between the ages of 21 and 44. Although older folks are being affected because of decreased immunity functions. Although men are affected 74%, females 26%, the fastest growing group in the U.S. is females. Although elderly people are catching up because of their use of unprotected sex. You have the baby boomers, the drug abusers are getting up there in age. The use of prostitutes by older men. So HIV is a virus. It's a parasite looking for a way into a cell. So for a way to take over the cell and to force the cell to make more copies of the virus. So that's how HIV works. HIV belongs to a family of viruses called retroviruses. Retrovirus, basically the transcription of the genetic material is reversed. The RNA is made into DNA rather than the normal pattern from DNA to RNA. Now, reverse transcriptase is an enzyme that's responsible for transcribing RNA into DNA, and attacks and destroys the immune system. And like we said, it's parasitic, so it must be inside the living cell to replicate. So human cells are double-stranded, and HIV genetic material is single-stranded. So it requires an enzyme, like we talked about, reverse transcriptase, to make a single strand convert to a double strand. So the viral genetic DNA matches the human DNA. So that's how HIV works. So let's look at the life cycle. On page 359, there's a picture of a HIV cell and life cycle of HIV. Basically what happens is the virus penetrates the body via the blood and body fluids. There's two protein markers that protrude from the virus. Those are GP120 and GP41. Now they attach to protein markers found on macrophages and T4 helper cells, or CD4, and infuse genetic material into the host cell. Now the virus is attached to these receptors, and both markers must attach to the receptors to enter the cell. So normal immune response when first infected with HIV is basically the B cells make antibodies. T cells mediate a cellular immune response to viruses trapped in the lymph nodes, and the normal lifespan is usually 100 days. HIV infected cells die in 2 days. Now, so your normal lifespan of a cell is 100 days. If they're HIV infected, they basically live 2 days. Now, CD4, the normal serum level is between 800 and 1,000 cells per microliter of blood. Now, immunity is compromised when the count drops to 200 to 499. They're also called severely compromised if it's less than 200. So there's a war going on between HIV and the immune system in the body. Now, all the people with AIDS have HIV, but not all HIV infected people have AIDS. What happens is that there's billions of copies of the HIV virus are made. 21 billion new HIV virins are produced daily. Only about 2 billion new T cells are produced daily. So eventually, basically, the body is unable to maintain a healthy immune system response, and they start showing the symptoms of HIV and AIDS. Now, the body's response to the HIV infection, basically it mounts a defense against the HIV virus through antibodies and T cells. So the initial infection is called viremia. About 12 weeks after the infection, the body produces enough antibodies or seroconversion to be detected by standard HIV testings. Now, this can be detected at 6 weeks to 6 months after the infection. Now, the HIV viral load begins to drop, indicating a partial effectiveness of the body to rid itself of the HIV. But the CD8 cells drop dramatically in the late stages, and the CD4 cells slowly decline throughout the whole infection. Now, during this stage of viremia, where there are large amounts of the virus in the blood, this is very contagious to others. So a person with HIV can transmit the virus to others at all stages, but a recently infected person has a high viral load, and those at end stage without drug therapy can be infectious also. So when we talk about viral load, we're talking about the amount of HIV in the blood. Like we talk about, it peaks usually within the first 2 to 6 months after the infection, again also in the late stages, so 10 years plus. And people that are infected can transmit the disease within a few days of being infected. Now, the spread comes from infected fluids. We're talking about transmission routes. It comes from infected fluids being exposed to mucous membranes. So, rapid transmission means that it can be transmitted with only a few days of being infected. HIV has been isolated in most body fluids of patients infected with HIV, even corneal and brain tissue. So the virus is mostly found in seminal fluid and blood, but it can be in vaginal secretions. So usually it's sexually transmitted. You want to teach people the ABC, safe sex method, which is abstinence, be faithful, and condoms. Now, even though protection from latex and polyurethane condoms, sex with an HIV-infected partner can lead to the disease. So, gender, sexual acts, and viral load all affect the transmission. So, those that are at high risk are those with genital, anal, or oral contact with exposure of mucous membranes to affected semen or vaginal blood secretions. The person receiving the semen is at greater risk. Women in heterosexual intercourse are at greatest risk for that. Greatest risk is any kind of unprotected anal sex, people with multiple partners, or STDs. Now, all donated blood nowadays is screened, but there is a lag time between exposure and HIV antibody. So blood can show up negative, tested for HIV. So with we know that sharing or reusing needles is a big transmission route. If somebody is going to reuse needles, they need to fill and flush with clean water, then flush them with bleach, then shake the syringe for 30 to 60 seconds filled with bleach to sterilize those. We also know that healthcare workers are at great risk for needle sticks. Needle sticks are the main reason for occupation-related HIV infection in healthcare workers. You also always want to use standard precautions, okay, with HIV. So there's no need to be gowned up, to be masked, all that other stuff. Through blood and parenteral, transmission routes, there's about 1% of cases from tainted blood have been noted since 1985. Like we talked about sharing of needles, the programs, we talked about cleaning the needles. Other transmission routes will be accidental or occupational, so deep puncture wounds from large bore needles, or those with a large viral load. Splash exposure from mucous membranes, lesions, cuts, all those type of things. Those are all transmission routes. Perinatal transmission routes. Usually these are 25% of risk to an infant that's born to an untreated mother. So 25% of those infants born to untreated mothers are at risk for developing HIV. If the mother's being treated, the percentage drops to about 8%. This is the most common route. Childbirth is the most common route for children. It crosses the placenta, in the blood, vaginal secretions, and breast milk. So transmission routes, like we've talked about, it occurs during pregnancy, can be done during breastfeeding. About 1 in 4 infants born to untreated HIV-infected mothers do develop the virus. HIV is, or AIDS is, among the top 10 causes of death in children. Mothers Okay, so mothers that start on their meds at 14 weeks of gestation, like we talked about, the risk factor drops to about 8%. These mothers need to be instructed to continue taking their meds throughout the pregnancy. So, some ways that HIV is not transmitted, cannot be caused by casual encounters such as hugging. Toilet seats is not a transmission route. Sharing any kind of household utensils or towels is not a transmission route. Mosquitoes are not transmission routes, and neither is shaking hands. So, let's look at the different stages of HIV infection. Stage 2 is basically confirmed HIV infection. The CD4 plus the T cell count is 200 to 499. There's an increased viral load. There are earlier signs and symptoms become worse. So there's stage 1 and stage 2, excuse me. Stage 1 basically is the first stage, okay? The HIV infection is confirmed, and usually this is done by an ELSA test, also can be done by a Western blot test, where they analyze the CD4 plus the T lymphocyte count and the percentage of the presence of or absence of the 26 AIDS-defining conditions. So, stage 1 is confirmed HIV infection. The CD4 and the T cell count is greater than 500. The symptoms are usually going to be vague and nonspecific. So you're going to have fatigue, headaches, low-grade fever, night sweats, persistent generalized lymphodenopathy. Their high-risk behavior usually continues since many of them don't know that they are infected. Now, stage 2, you're also going to have confirmed HIV infection. The CD4 and T cell count is going to be anywhere from 200 to 499. These people are going to have an increased viral load. So your earlier signs and symptoms are going to become worse. They're going to have severe fatigue that interrupts their ADLs. Usually going to have a persistent fever. They're going to have frequent drenching night sweats, chronic diarrhea, and reoccurrent headaches. Now, stage 3, we're going to talk about, of course, they have confirmed HIV infection. Their CD4 and T cell count is going to be less than 200. Now, a person with a higher CD4 and T cell count, but also these people are usually going to have a opportunistic infection. Like I said before, a person with a higher CD4 and T cell count, but also has an AIDS-defining illness. If you look on table 21.1 in IGI, this will show you that. They can also be considered a stage 3. Now, opportunistic infections are those infections caused by organisms that are present as part of a normal environment and usually kept in check by a normal immune system or immune function. And these infections usually are caused by because they have immunosuppression. Usually thrush or candidus is the most common. Now, stage 4, of course, you're going to have confirmed HIV infection. There's no information regarding the CD4 or T cell counts, usually because they're so low. And also, there's really not any information on percentages or illnesses by the age-defining illnesses as you see on table 21.1. So medical diagnosis of AIDS, of HIV, like we talked about, HIV diagnosis, you're going to have a positive HIV antibody test, usually made within 3 weeks to 3 months. This can be done by ELSA test, which detects serum HIV antibodies. If these are positive, additional testing is used to confirm or rule out whether they have HIV. Now, the Western blot test is usually used as a confirmation test if the ELSA test is positive. If this Western blot test is positive, then they are given a diagnosis of HIV. So, some health histories that are you need to know about. Tobacco and alcohol use, any kind of illegal drug use, or occupational history. Do they have did they work in some type of field where they would have got a needle stick or been in contact with any kind of fluids? Their sexually transmitted infection history. Do they have a history of any kind of sexually transmitted diseases? Their medication history and allergies. What kind of family history do they have? What type of health was their mother in? Could this have been something that was transmitted from their mother? Their sexual history. Also their needle and blood exposure history. Do they have a problem with hemophilia, with a clotting factor? Did they have any blood transfusions between 1978 and 1985? Have they had any major infections such as TB, hepatitis? All these things put them at risk. You want to assess for signs and symptoms. So the most common sites are going to be your lungs, mouth, GI tract, skin, blood, and central nervous system. So the first manifestation of HIV is usually fever, night sweats, chills, headaches, muscle aches, flu-like symptoms. With an acute infection, they could have a rash or a sore throat. So any changes in these systems should be reported to a nurse or physician. You also need to assess how much the patient knows about the disease and the treatment. You need to assess how well they can cope with the disease and their understanding of safe sex practice. You have to remember that you have to teach these people that infection is the leading cause of death in these patients. So any type of infection, any changes in any of these, that's why it's important that they report to a nurse or a physician. On your physical exam, you're going to look at everything: height, weight, vital signs. You're going to look at their skin. Is it dry? Do they have slow wound healing? Any kind of lesions? You want to look at their head, ears, eyes, nose, and throat. You're going to look at their lymph nodes, lymphatic system. Do they have any lymphedema, lymphadenopathy? Respiratory system. Are they having any problems with shortness of breath? Do they have a cough? Their cardiovascular system. You want to look at their abdominal area. Are they having problems with nausea and vomiting, weight loss, diarrhea, musculoskeletal? Do they have decreased energy? Are they having body aches? Neurologic, do they having any problems with headaches, confusion, fever, visual or memory changes going on? Their GU system, GI-GU system. Laboratory profile, you're going to look at their CBC count, their CD4, CD8 counts, and ratios. Usually your white blood cell counts, they need to be greater than usually their white blood cell count, is going to be less than 3,500. You need to assess not only that, but you need to assess their psychosocial support system. You need to find out who you can and cannot talk to, because this is a big disease with a lot of issues behind it. A lot of people don't want everybody knowing that they have this, so you have to find out who you can talk to about this and who you can't in their family. Their closest person might not be their legal kin or legal guardian. who's their power of attorney, who's their health care proxy. You're going to need to assess, are they able to do their daily activities of daily living? Are there going to have to be changes made? What is their anxiety level, their mood levels, their self-esteem? Do they have suicidal ideations? All this is part of the psychosocial system that you're going to have to help them with and find them support for if they have any issues. Now, medical treatment, those who are diagnosed are going to have to take lifelong, around-the-clock medications. They can't miss any doses because this is going to lead to resistant strains being developed if they do. The cost is usually about $20,000 a year, plus any cost for additional meds because of infections that might be going on. We're going to talk about heart therapy, which is basically highly active antiretroviral therapy. It's recommended for HIV viral load of 5,000 to 30,000 copies per ml and a CD4 count of 350 to 500 cells. Usually it's a drug cocktail, combination drug. It's going to be a protease inhibitor and two nucleoside reverse transcript inhibitors. So they have to take this cocktail. If they only take one medication, it's not going to improve the duration or quality of their life. Some medications that you're going to see with this are going to be your Retrovir, which is your most common nucleoside reverse transcript inhibitor used to treat HIV infection. Some common problems, side effects you're going to see with this are going to be your GI upset, fatigue, anemia, shortness of breath, headache, nausea and vomiting. A lot of times you're going to see people that because of the GI upset is the reason that they don't take the medications. Most of the side effects usually will subside within a couple of weeks. So you need to make sure you educate these people when you start these medications. You want to educate them on the side effects. They're going to have to look for side effects with anything that's over the counter or any prescriptions they're taking at the time. If they do not take these medications, they can develop resistant mutations. So, your NARTs, which is your your nucleoside analog reverse transcript inhibitors, or NRTIs. They're going to suppress your reverse transcriptase. They're going to also inhibit the viral DNA synthesis and replication. So they're going to help to kill the virus. Examples of these we talked about: Retrovir, also Combivir. Now your non-nucleoside analog reverse transcriptase inhibitors, or your NNARTIS. They inhibit the synthesis of RT. They also suppress viral replication, but they do not kill the virus. So some examples of that are your Viramune, also your Sustiva. Some protease inhibitors that are used, your Norvir, your Virucept. These are going to block protease enzyme, which basically breaks down large proteins into smaller active ones that carry viral particles out of the cell. This is going to help to prevent viral replication and release of viral particles. Meds cause the protease to work on drugs instead of the protein chain. Now, your fusion inhibitors basically are going to block the ability of the HIV cell to fuse with the host cell. Examples of these are going to be Fuson, your combination products, which is your combination of two different NRTI. They generate bad nucleotide building blocks. Example of that is going to be Combivir. Now, your interventions for HIV infection, you're going to have early detection and prompt treatment. Those are vital. They could be on anti-infective drugs prophylactically. It's important for these people to take the drugs as prescribed. They may need IV antibiotics, and that could be at clinic or home administration. Remember, stopping antibiotic therapy can result in an incomplete treatment and the development of resistant organisms. Now, these people need to avoid exposure to infections. So a patient that is infected needs to have a private room. They need to limit the number of visitors. They need to have Q4-hour vital signs. They need to have their skin inspected every 8 hours. Inspect the skin for any kind of open areas. They're going to need a low bacteria diet, so no raw fruits, vegetables, or salads. You need to remember that. No fresh flowers, no indwelling catheters, and only healthy visitors. So nobody that has a cold, anything like that. They're going to have impaired oral mucous membranes, so you're going to encourage regular teeth and mouth cleaning with dental floss and a soft toothbrush. You're also going to encourage fluids to maintain hydration and to keep the mucous membranes open and moist. Not open, but moist. Excuse me. You're going to use topical anesthetics are going to be applied before eating. Okay? And we're talking about people that have thrush in their mouths. You also want to encourage regular dental evaluations to help prevent and manage any kind of oral diseases or infections. Usually these people are going to be people with thrush are going to be treated with diflucan, Noserol. They also might have a swish and swallow. Type thing, an anesthetic for their mouth. Mouth care, you want them to swish with some kind of bicarbonate. Okay, you don't want them anything that's acidic, because that's just going to inflame it even worse. And you're going to have them use mouth ice chips to help soothe that mouth, those inflamed membranes. For pain, basically you want to use comfort measures for these patients. So it's going to be mattress pads, hydrotherapy, careful moving of them. You're going to use NSAIDs for any kind of myalgia or arthralgia. Remember, from opportunistic pain is going to be from opportunistic infections and viral invasion into the nerves and muscles, malignant tumors, diagnostic procedures. You need to closely monitor their pain level and their medication use. You want to use a flow sheet of pain reports on a 10-point scale, and you want to treat their pain. If they're having problems with depression, you want to treat them with tricyclic antidepressants such as Elavil. If they're having peripheral neuropathy, you're going to treat them with the Elavil plus Dilantin anticonvulsant. For pain and the amount of medications used to guide the nurse and physician, it's appropriate. You need to check the appropriate amount of pain medication, what works best for the patient. What works best for one patient might not work best for the other. Usually you're going to use opioids in some way. They could use oxycodone, morphine, Dilaudid, Duragesic patches, any of these medications. You just have to find the right amount and the right medication that controls that patient's pain. As we talked about anxiety, you got to remember these patients are going to be dealing with emotions of facing this life-threatening illness. You're going to encourage the patient to ask questions and talk about their feelings. You're going to give them information about the disease and treatment that can help them and their family deal with this anxiety. You also need to get others involved, so social workers, chaplains, mental health counselors. You also remember these patients might have low self-esteem issues. You want to help them express their feelings. You want to make them feel comfortable. You do not want to have social isolation, so you're going to promote interaction. You don't want to isolate these patients. You don't want to... we talked about using standard precautions with these patients. Don't treat them, we always say the term, don't treat them like a leper. You don't want them to feel like an outcast of society, okay? We talked about the ways of transmission. They're not going to, because you walk in a room with somebody who's HIV infected does not mean you're going to get the disease, okay? You do not want to socially isolate this patient. You want to have a therapeutic relationship between you and that patient. So, these patients are usually going to have decreased appetite due to fatigue, anorexia, nausea and vomiting, diarrhea. Could be because of difficult swallowing or painful swallowing. They could have wasting syndrome, so they're going to have an imbalanced nutrition, less than body requirements. You need to refer a dietitian for counseling as soon as the patient's diagnosed, so that they can get them the right protein, the right calories. They need to have at least 3 liters of fluid a day. Okay. They could need oral supplements. to help with their nutrition. If they can't swallow hard foods or regular foods, they might have to have a liquid nutritional supplement. You might have to administer medications to help with their diet. So to improve appetite, they could be on Megastrol. They could be on I can't remember the name of them right now, but they're made from marijuana. THC helps to improve their appetite. Pills usually. To relieve the nausea, they could be on Zofran. They could be put on Phenergan. To control diarrhea, they're going to be on any kind of anticholinergic. So some interventions. Sometimes they're going to have disturbed thought processes. So patients with HIV encephalopathy may experience cognitive and motor impairment. You're going to assess their baseline. You're going to try to reorient them. These patients might withdraw from social activities because of embarrassment. They could become angry or hostile. Safety is consistently going to be reevaluated based on their mental and physical capabilities. They could be put on psychotropic drugs, antidepressants, anxiolytics. They could be put, depending on what's going on with them, you're going to have safety issues, and so you're going to have to reevaluate those and try to give medications to try to calm their nerves or so that they don't hurt themselves. Now, opportunistic infections you're going to need to watch for. These are caused by organisms that are present because of the normal environment. Like we talked about, they're going to have a compromised immune system, so they're normal normal infections that our bodies fight off every day that are just normal, that we have, that are nothing to us, are going to become deadly for these people. So when the CD4 cells and the CD8 cells and the HIV antibodies fall below normal, infections and cancers can take advantage and can cause infection or cancer in the bodies. That can be anything: bacterial, fungal, virus, parasites. Now, these aren't going to be threats to any kind of the healthcare worker. It's only going to be a threat to the person that's infected. Now, remember, this is the leading cause of death in the AIDS patients, and it's usually caused by pneumonia from unspecified organisms. So you have to be very careful with these patients. So some parasitic infections they could become infected with, and you'll need to know some of these. Your PCP, and I'm not going to try to say what kind of pneumonia, pneumocystitis, UroVC pneumonia, signs and symptoms are going to be shortness of breath on exertion, fever, tachypnea, fatigue, weight loss, a persistent non-productive cough. Their diagnosis is going to be by a chest x-ray, sputum sample, or bronchoscopy. Treatment is going to be Bactrim, clindamycin, those type of medications. Now, This was once thought to be caused by the protozoan pneumocytosis, pneumocytis carni. Most think it's a fungus caused by inhalation. This is the most common opportunistic infection in HIV patients, and basically it cysts in the lungs that prevent gas exchange. Some other parasitic infections, your crypto sporodosis, or your isosporosis. Okay. Your signs and symptoms are going to be watery diarrhea, may be severe and persistent, with abdominal pain, weight loss, and nausea. This is fairly common in the environment from birds, fish, and reptiles, and in humans. Settles in the small intestine. Like we said, the symptoms range from mild diarrhea to severe wasting and electrolyte imbalances. Diarrhea of up to 15 to 20 liters a day, fluid loss. This is what it's going to cause. So, diagnosis is based on laboratory examination of a stool specimen. Nursing care for this is you're going to try to prevent dehydration and maintain their fluid and electrolyte balance. You're going to use antidiarrheal drugs, intravenous fluids, antimicrobial agents, and you're going to teach good hand hygiene and personal hygiene. Candidiasis, which is basically thrush, found in most food, soil, and inanimate objects. Approximately 80% of HIV patients develop this because the immune system can't control its growth. Candidal plaques can be scraped off. They appear like cottage cheese or yellow-white in the mouth, or could be in the vaginal region, anus, peritoneum, axilla, under the breast. Basically a yeast infection. You want to inform the patient that it does reappear, and they need to monitor for reinfection. Like we said, risk factors are going to be immunosuppressed, long-term antibiotic use, diabetics, those are obese. Signs and symptoms, like we said, the oral white plaque, lesions in the mouth, esophagus, trachea, bronchia, and lungs. Pain and tenderness, vaginal, it's going to be a white discharge, pruritus. Treatment is going to be antifungals, hygiene. You're going to maintain dryness and change the linens. This is also going to make their mouth sore, painful swallowing, so their foods are going to taste different. So you're going to have to watch their appetite also. Another infection that is most common with AIDS patients is going to be your crypto caucasus. Basically, you're going to have signs and symptoms of fever, headache, malaise, nausea and vomiting, altered mental status, and a stiff neck. The symptoms are going to appear approximately 30 days after exposure. This disease can progress to meningitis. A treatment for this is going to be an antifungal. your MAC, or Mycobacterium avium complex. Signs and symptoms of this. This is a bacterial infection. It's the most common bacterial infection associated with AIDS. Signs and symptoms are going to be fever, fatigue, weight loss, night sweats, abdominal pain, and diarrhea. This bacteria can be found anywhere, mostly in food, animal, and soil sources. It can affect any organ of the body, meaning it's a systemic infection. It's not contagious. Diagnosis is going to be done through small bowel biopsy and culture, AFB stain or culture. Treatment is going to be Biaxin, rifampin, Cipro, Zithromax, those type of medication. That's why you want low bacteria diets with these patients. That's why they can't eat raw fruits, raw vegetables, have any kind of fresh flowers in that, because they could pick up some of these infections because of that. Another bacterial infection that they see in AIDS patients, HIV patients, is going to be your TB. HIV patients are more likely than a healthy person to become infected with TB because of their CD4 count dropping. HIV patients might not have a positive TB test, even with TB, if the CD4 count is less than 200. So their CD4 count might be less than 200. They're not going to show positive for a TB test. So signs and symptoms, of course, are going to be a productive cough, a fever, night sweats, weight loss. Diagnosis is going to be done through a chest x-ray, a sputum for AFB and culture. Your treatment is going to be inhalers, rifampin, streptomycin, respiratory isolation. These patients are going to have to go for a 6-month follow-up. And most of these patients are going to have TB sites outside of the lungs, so signs and symptoms are going to vary with the site. Another bacterial infection is bacillary angiomatosis, or BA. Signs and symptoms are going to be skin lesions, papules, and plaques. Now, this can affect any organ. It's transmitted by cats and their fleas due to a bite or a scratch. These papules or plaques can occur anywhere on the skin. You want to make sure that the HIV patient needs to try to avoid any kind of rough play with cats. Also want to make sure that they have cats, that these are treated for fleas, being treated for fleas. Viral infections that these patients might have, the cytomegalovirus, or CMV. Usually it's found in semen, cervical secretions, saliva, urine, blood, and organs. Mainly it's transmitted by blood and body fluids through unprotected sex. It can affect the eyes. Retinitis, and that could lead to total blindness. It also can cause encephalitis, pneumatitis, and hepatitis. So signs and symptoms are going to be stomatitis, esophagitis, gastritis, colitis, bloody diarrhea, pain, weight loss. Diagnosis is going to be done through an endoscopy or culture and biopsy. Treatment is going to be granciclovir, foscarnet, or cytofovir. Excuse me. Like we said, complications can be subacute encephalitis, colitis, esophagitis, pneumonia. All those things can be complications of the viral infection. Another viral infection could be the OHL, or oral hairy leukoplakia. This may be the earliest indication of a HIV infection. It's usually associated with the Epstein-Barr virus, most commonly seen among smokers. And this may indicate the disease has progressed. So your signs and symptoms are going to be thick white patches on the buccal mucosa, soft palate, floor of the mouth, and the tongue. The mouth is usually often painful, so you're going to advise the patient to drink from a straw. You're going to ice cream and popsicles can help numb the area. Hot and spicy foods and alcohol are going to exacerbate the pain, okay? Another viral infection is your herpes simplex virus, or HSV. HSV infection follows a predictable pattern, primarily a primary outbreak, latency, and possible reactivation at some later point in life. HSV-1 is basically on your mouth and nasal lesions. HSV-2 is genital and perianal lesions. Now, reactivated HSV and HIV patients can cause serious disease and tissue destruction. It's more widespread and it lasts longer in patients with HIV/AIDS. So what it does is it will lay dormant along the nerve and reactivates, and then lesions develop. Now, triggers for activation of the HSV virus are going to be stressors. It could be psychological or physiological, or direct contact. Now, oral outbreaks last about 3 to 10 days, and they're contagious for about 3 to 5 days. So your signs and symptoms are going to be tingling and burning for about 24 hours before a lesion. You're going to have isolated or grouped vesicles on a red base. Usually these are painful. They're going to have fever, bleeding, lymph node involvement. Diagnosis is going to be done through a viral culture. Treatment is going to be through acyclovir or famvir. The HZV or herpes zoster virus. Most adults carry the HZV because they had exposure to chickenpox as a child. Reactivation of HZV usually occurs as shingles. Basically, it's reactivation of dormant bacilli, which stays dormant at the nerve root, and that could be cranial or spinal nerves. Basically what happens is it starts at the site that's supplied by the nerve and leaves nerve ganglia through body fluids, erupts usually after several days of discomfort or minor irritation, itching to severe deep pain. It lasts several weeks, and it can occur in the immunosuppressed, and it is contagious to those without chickenpox or that have been unvaccinated. Now, the blisters are going to be contagious. Your signs and symptoms, like we said, rash along the dermatonal planes, pain, pruritus, fever, malaise, fluid-filled blisters. Your treatment is going to be pruritic comfort, antivirals such as acyclovir, Zostavax injections, or complications are going to be post-herpetic neuralgia. Usually in older patients, they're going to have shingles, they're going to have nerve damage, skin necrosis and scarring, Bell's palsy. They could end up with eye infections. Just an example, my father had the shingles come back up, had the HZV come back in his later life. He ended up with shingles and nerve damage. He was on Neurontin, his whole left side. You couldn't touch him there or he would scream in pain. It hurt so bad. So it is a very debilitating disease. Some other viral infections, your progressive multifocal leukin encephalopathy is caused by the Jamestown Canyon virus. Develops in about 2 to 4% of AIDS patients. Is progressive degeneration of the white matter of the brain. Usually death occurs within 4 to 6 months after the onset of symptoms. So your signs and symptoms are going to be weakness and progressively impaired speech, vision, and motor function. There is no effective treatment. What you want to do is try to maintain low viral loads through antiretroviral therapy. Is usually the best strategy for preventing PML. Kaposi sarcoma, which is basically it's a neoplasm that develops because of AIDS. When it's seen in the skin, there are usually no symptoms. Basically, they end up with red blotches or purple blotches on the skin. When it affects the GI tract, usually there's bleeding that may result causing anemia. When it affects the respiratory system, hypoxia can occur. So your signs and symptoms are going to be, they're going to appear as firm, flat, or nodular, hyperpigmented lesions, painless, non-pruritic, usually purple in color. But they can be also pink, red, brown. Basically what it is a tumors. They're small tumors within the blood vessels that erupt. They cause the blood vessels to erupt and cause these neoplasms. Those tumors can spread to the gastrointestinal and the lungs. So like we said with the lungs, they could have shortness of breath, dyspnea, respiratory failure. GI, they're going to have diarrhea. Sometimes they can get lesions in the mouth and other parts of the GI tract. Treatment is going to be through observation, through heart therapy, the drug HAART, H-A-A-R-T, surgical remover, cryotherapy, radiotherapy, or chemotherapy. And this is just a picture of what it looks like on the skin. And there's another one of what it looks like in the mouth. Now your lymphomas, immunodeficient patients have a 14 times greater risk for developing lymphomas. This is the second most common malignancy in AIDS patients. So lymphomas are basically a type of cancer that originates in the lymphoid tissue, bone marrow, spleen, thymus gland. There are two types. There's Hodgkin's and non-Hodgkin's. Signs and symptoms are going to be fever, night sweats, and weight loss. Diagnosis is done based on a biopsy of the lymphoid tissue. Now in pediatrics, HIV is usually, in infants, it's usually going to be detected in the first 6 months. They're going to develop signs and symptoms by 1 to 3 years old. Their average lifespan is going to be 9.5 years. Now, all infants born to HIV positive mothers will test positive at birth until about 18 months of age. Now, if a mother is untreated, 20 to 50% will develop AIDS in the first year. Usually it's done by opportunistic diseases. It's usually what the death rate is from. So they're going to be at increased risk. A child with a fever, circulating antibodies secondary to lack of previous exposure to pathogens. It can be also caused by immature immune system. So you want to avoid any kind of exposures to any kind of infections. You want to have prompt, aggressive treatments for any kind of infections. Now you got to remember, with pediatrics, this is only 1 to 2% of any kind of AIDS cases that are reported. Incubation with these patients is more rapid, so you need to have fast, effective treatment, aggressive treatment. And so that's going to end my HIV part of the lecture, and we will go on to the next one in just a minute.